Thanks a lot, Dave, for the introduction. And I want to thank the organizers and Dave for the invitation to speak to you today. It's really an honor to be here, and I'm really looking forward to giving this talk. Okay, so today I'm going to talk to you about, as Dave said, utility of EM in renal biopsy interpretation. And this is not a novel topic. This has been written about extensively. Here's just a partial list of some of the papers where people have written about this and done an excellent job. I want to call your attention to one of these papers in particular. This paper here was written by Mark Haas almost 30 years ago, where he really did a great job of not only making the argument that EM is incredibly useful in renal biopsy interpretation, but really kind of quantified exactly how often is it useful. And it turns out in at least about half the time, EM provides useful diagnostic information. So my purpose today is not to convince you that EM is useful. I know this audience already knows that. It's really more, I guess, essentially to entertain you with some cases that I think are interesting and illustrative examples of some of these subtypes of EM utility in the renal biopsy. And in particular, I'm going to show you a couple of cases in which EM is absolutely required for the diagnosis. I'll show you a couple of reasonably common entities that can sometimes look exactly alike by light and fluorescence microscopy, but EM totally separates them. And lastly, I'll show you a transplant case where something totally weird and unusual turned up that was unexpected. And in the interest of time, I'm just going to focus on glomerular pathology. So let's get right into the cases. First, this was a 70-year-old male with a history of hypertension, hyperlipidemia, presented with a bunch of weight gain and edema. And his UA showed 3+ blood, protein, packed RBCs. His serum creatinine was 4. His baseline was somewhere probably about 1.1. His urine protein to creatinine ratio was 4.6, so he had heavy proteinuria. His serologies, ANCA, anti-GBM, and ANA were all negative. He was mildly hypocomplementemic, slightly low C3, and sort of low normal C4. So they got a biopsy in him, and it kind of wasn't a very good biopsy. But we got a little piece of cortex. There are a few glomeruli there, and there are some that are sitting in the blood and exudate that I'll show you. But one thing I think you can appreciate when you look at the glomeruli, they were markedly abnormal, very hypercellular, and there was cellularity both endocapillary and mesangial. Here, and I hope you can appreciate on this stain, this is a PAS stain, that there's quite a bit of this sort of lobular accentuation, this idea that the glomeruli look like collections of balls of cells. And when you look at it a little higher power on the silver stain, you can see glomerular basement membrane duplication, double contours, along with the this hypercellularity and cellular interpositioning. This is a sort of a good example, I think, of a membranoproliferative pattern. So the patient had this membranoproliferative pattern on a light microscopy, and then fluorescence showed some interesting findings. The IgG that we see stained here shows a really distinctly linear pattern in many of the glomerular capillaries. Now, also interesting, it wasn't exactly entirely continuous. It was somewhat discontinuous in some areas that you can see broken up here, but really convincingly linear, I think. The C3 showed a similar pattern, but maybe a bit more discontinuous. There was no C1q, IgM, or IgA, but the light chains that I'll show you here are restricted to lambda. And again, the same pattern of this linear staining of these peripheral capillary loops and really no staining for the kappa. And this just show you that both stains actually work. Okay, so our findings, we have a membranoproliferative pattern. We've got glomerular basement membrane staining that's linear, although a bit discontinuous with IgG lambda. We didn't do subtype performing back then. And there was linear C3, but that was a bit more discontinuous. And there was no extraglomerular deposits or staining. So what's the differential diagnosis? So here's some of the things that we considered. The first was PGN mid. Dave's already just talked about that. Type 1 cryo would be considered something called atypical anti-glomerular basement membrane disease and immunotactoid and fibrillary. So I'm just going to briefly go through these, very, very briefly, and talk about PGN med. These patients typically present with heavy proteinuria. About 70% of them will have nephrotic syndrome. Hematuria, very commonly, about 80% of these patients. About 2/3 will have renal insufficiency, but although RPGN, rapidly progressive GN, is actually uncommon. Most of these patients have a proliferative pattern. It can be a membranoproliferative pattern like we see here, sometimes mesangial or endocapillary proliferatives, rarely other patterns. And by fluorescence, just like we saw here, there's a single IG staining. IgG3 kappa, like Dave showed, is actually probably the most common. The staining is typically granular, though, and C3 is always present, essentially. C1q a little bit less commonly, about 2/3 of the time. And again, there's no extraglomerular deposits with PGN-MID. By electron microscopy, you see granular deposits in mesangial, subendothelial, and sometimes subepithelial locations. Laboratory-wise, these patients don't have cryoglobulinemia. And what I think is very interesting about this, even though we get this light chain restricted staining in them, the rate of detecting a circulating monoclonal is actually uncommon. Only about 1/3 of the patients. And even when they do look at bone marrows, it's still equally low prevalence, about 25 to 30% of those patients. Most of these patients don't have hypocomplementemia, although you can see it in about 20% of the time. So this is not bad for our case. Let me just go through a couple of others. Type 1 cryoglobulinemic glomerulonephritis. These patients, it's associated with lymphoproliferative disorder. And the symptoms that they present with are usually symptoms of some kind of hyperviscosity associated with their cryoglobulin. Epistaxis, blurry vision, mental status changes, for example, Renal, non-healing ulcers. They sometimes can get some of the other manifestations that you see with cryoglobulinemia, that have a systemic vasculitis with rash and that, but that's more common with type 2 and type 3 than this. The pattern that you see by light is usually proliferative, membranoproliferative included in that, and they can also have arteritis that you can see in the biopsy occasionally. By IF, again, it'll be a single IG staining, usually IgG1 and IgG3 are most common, but others can sometimes be seen. The staining is typically granular and maybe even chunky. C3 and C1q are common, and they're very commonly, you'll see luminal deposits, that is, these cryoglobulins within the capillary lumen, and sometimes vascular deposits. And by EM, the classic appearance of these short microtubular deposits, I'll show you an example of that in a second, in a variety of locations. And of course, there are these crystal variants, which I'm not going to talk about. And again, laboratory-wise, these patients will have evidence of a cryoglobulinemia. This is a case of a type 1 cryo that I had some time back to show you what these cases look like. You see this kind of chunky deposits in the subendothelial, but also you see these non-argyrophilic, this is a silver stain on the right, these non-argyrophilic luminal deposits that you often see in these. And these deposits in this case were IgG kappa. Okay, and here's these really nice, beautiful, sort of short tubular deposits that you can see in cryoglobulinemic GN, although, as I said, you don't always see them. Okay. However, in our case, the patient didn't have cryoglobulinemia. All right, let's talk about atypical anti-GBM disease in the differential. This is a maybe somewhat controversial diagnosis in the literature. I know some people debate its existence, although there have been at least 5 series, which I've highlighted down here at the bottom, of multiple patients with this, and probably another half dozen case reports on top of that. And it's estimated that atypical anti-GBM disease accounts for about 10% of all the cases of anti-GBM disease. The patients with the atypical form, it's much milder clinical presentation. The average serum creatinine presentation is about 1.6 to 2.9. The nephrotic range proteinuria, about 1/3 to half. Alveolar hemorrhage is much less common in this than in typical anti-GBM disease. Although in the most recent series, which were just published, about 30% of those patients, 20 to 30% of those patients had alveolar hemorrhage. Nevertheless, overall renal survival is decent, about 70 to 85%. By light microscopy, the original series that was published back in 2016, 90% of those patients had a proliferative pattern. Membranoproliferative predominantly, but endocapillary or mesangial proliferative also. And this pattern varied in some of the other series that I've shown here. But the bottom line is it's less often crescentic that you see very, very commonly in about 80 to 90% of cases with typical anti-GBM disease. There's linear staining of the GBMs for IgG in atypical anti-GBM disease, and it's light chain restricted, at least in the initial series, 9 of the first 10 cases. Subsequently, much fewer than that, but still you see light chain restriction in a number of these. And this disease is characterized in part by what it doesn't have. By electron microscopy, you see no deposits, and you're unable to detect serum anti-GBM antibodies measured by conventional assays that are usually typically ELISA against the alpha-3 NC1 domain of type 4 collagen. Pathophysiology of this incompletely understood. That maybe there's some evidence that there are conformational epitopes in that same domain. Highlighted a recent paper that sort of provided some evidence of that. Other alpha chains, some linear epitopes of the collagen, et cetera, are some examples of why this might be atypical. And last, in the differential immunotactoid and fibrillary, I'm not going to say very much about these. The main reason I put this here is that fibrillary, on rare occasions, has been shown to show staining in a linear pattern. Both of these are readily identified by electron microscopy with structured deposits, immunotactoids, typically these parallel tubular deposits, and fibrillary with these fibrils that look amyloid-like but are a little thicker. Okay, so let's go back to Ian for the case that we started with, now that we kind of blathered on about the differential. Okay, so here's what we saw in this case. And what we can see is there's tremendous number of electron-dense deposits, primarily sitting in the subendothelial location here. And we can see glomerular basement membrane duplication as well as cellular interpositioning. And when you look at it this little bit higher power, you can see just this huge burden of deposits. The deposits have this sort of granular amorphous, just like typical immune type deposit appearance. But there's so many of them, they're contiguous essentially. And in some of the loops that you see here, for example, if I can get the mouse to work, they're smeared out almost like peanut butter. So just like smeared out all along the subendothelial surface. And this is better illustrated maybe even in this loop here where you can see this. Now, this is not a novel observation. Other people have written about this with this entity. But the bottom line is that this can make sometimes the fluorescence look like linear deposits. So diagnosis was PG and mid. So some follow-up on this patient. They did serum electrophoresis, immunofixation. Like we often see in these cases that I told you, it's all negative. Bone marrow biopsy, flow, negative. No monoclonal population identified. However, because of the presentation, they decided to treat the guy. They treated him with Velcade. And his serum creatinine improved to 1 to 1.2 within a month and a half. And it's about 1.5 a little bit over a year later. His urine protein to creatinine ratio went down to 0.8 within a couple of months. It's currently 0.2, and his edema has essentially resolved. Okay, case number 2. This is a 79-year-old man. History of diabetes for about 3 years, but he had this slow decline in his renal function. Serum creatinine 1.2 to about 2.5 over a year and a half. And he had lower extremity edema. And just like Dave said, sometimes they biopsy these patients. His urine protein to creatinine ratio shot up to 10. So they biopsied the guy. Now, he had much more IFTA, interstitial fibrosis and tubular atrophy, than the previous biopsy. We're not going to focus on that. But the glomeruli looked, I hope I can convince you, that looked quite cellular. And again, you can see this sort of lobular accentuation pattern. And we kind of zoom in on this. We look at this at higher power. You can see this double contouring that we talked about. And it's really a membranoproliferative pattern, just like the last one. And on his fluorescence, it looks like I substituted the same pictures, but it's not. This is a different case. What we see is on IgG stain, this really convincingly linear pattern all along these peripheral capillary loops. And again, it's somewhat discontinuous. It's broken up in a couple of areas. And the C3, again, shows the same thing, this linear staining of these capillary loops, but the sort of in this discontinuous pattern. And this also is lambda restricted, just like the last one. Okay, so same differential diagnosis, essentially. And this patient did not have a cryoglobulin. So let's go straight to the EM on this case. And what we see is there's a little bit of GBM thickening. Dave talked about this, a little bit of this segmental wrinkling, probably related to chronic ischemic changes in the glomeruli. But really, and a little bit of mesangial expansion. Some of this stuff is probably from his diabetic nephropathy, and he's got significant foot process effacement, but he has no deposits anywhere. No deposits in any compartment. So my diagnosis here was anti-GBM disease. Now this guy, they worked him up, and his SPAP did show a monoclonal spike. They did immunofixation. IgG lambda showed up, which is what we saw in the biopsy. And his bone marrow showed about 3% clonal plasma cells. Flow cytometry showed this minor population. So they treated him also with Velcade and Dex. His edema resolved. He had lost 21 pounds very, very quickly. His urine protein to creatinine ratio declined to 3.3 within about a month, and then a year later, it's 0.2, although he's had some significant CKD, but much improved. Okay, so let's get down to the last case, and this is where we have some unexpected findings. Okay, this is a transplant case. This is a 69-year-old male who underwent kidney transplantation. He had CKD since he was in his 40s. Presumed to due to hypertension, but they presume that a lot, and they don't ever often prove it, so they didn't really know, to be honest with you. He got a deceased donor, but this was a pediatric kidney transplanted en bloc. The child was an otherwise healthy child who had, with no medical history, who died in a fire. Patient had no PRA. And immediately worked, got great graft function. Serum creatinine went down to 1 very, very, very quickly. And within a month, his serum creatinine was 1. However, over the course of a couple of months, his urine protein to creatinine ratios increased. And increased to about 2.5 within a couple of months, 2.5 to 3 months, despite his serum creatinine remaining stable. He also had some microscopic hematuria. His blood pressure was reasonably well controlled, about 140 or so. And they didn't want to biopsy him initially because the kidneys were small. But by about 3 months, his protein to creatinine ratio kept going up, and it increased to about 3.8. And although he didn't have any overt signs of nephrotic syndrome, but he had this heavy proteinuria and persistent microscopic hematuria. So about 16 weeks in, they decided to biopsy him. Now, this biopsy didn't come to me. Initially, it went someplace else, but I was brought into the case later, which I'll tell you about in a second. But initially, this is what was seen. The biopsy, the glomeruli, showed sort of some mesangial expansion with maybe a little bit of mesangial hypercellularity. And the mesangium had this sort of almost kind of variegated appearance. And I'll show you sort of a higher power on the silver stain. You can see that there are foam cells here. I hope you can appreciate that. Podocytes are kind of plump and reactive. And really, those are the main findings. So this mesangial expansion, foam cells, and reactive podocytes. Really, fluorescence was all negative. No peritubular capillary C4D, no glomerular staining for immunoglobulin or C3, C1q. So really unremarkable. However, the EM showed numerous electron-dense deposits. And this is what you can see sort of at a low power, and they were, let's see if I can point over work, yeah. They were kind of in the mesangial and then some in the subendothelial space. And when you zoom in on these, they have a really unusual appearance, this sort of variegated, almost bubbly appearance. To me, they look like soap bubbles. And all of the deposits had this appearance. And here's another example of them. Again, lots of these sort of little bubbly, variably electron-dense deposits. And of course, we also, you could see the mesangial foam cells that we could see you could see on light microscopy. So, findings. There was no rejection in this case, no acute immune complex glomerular disease, and there was this glomerular expansion and foam cells. And then there were these unusual deposits on EM, mostly in mesangial and subendothelial locations. So I was consulted on the case, said, what are these things? And I'm sure many of the audience, particularly Giovanni, just gave her talk, says, oh, I know exactly what those are. I've seen these things before. And you can see these in different contexts. Here's an example of a patient that we had who had, with biopsy for another reason, totally different diagnosis. This patient had tremendous hyperlipidemia. Triglycerides were like 1,700 in this patient. And what you can see scattered throughout this biopsy, not as numerous as in our case, but these little bubbly deposits in subendothelial and mesangial locations. Here's just another example of this. It looks essentially just like our case. And this patient also had mesangial foam cells. So what are these deposits? I believe these are lipid lipoprotein deposits. And if you had frozen tissue, you could verify this by oral red O. However, they didn't have any left. So they're like, okay, great. You think these are lipid lipoproteins. What is it? How does that help us? And there were a couple of questions to try to resolve. First of all, did it come from the donor? Or is it come from the recipient? I favored that it was recipient disease based on the clinical presentation. I felt, but there was not all complete agreement on that in the team, but that's what I felt. But there still remained the question, well, is it a genetic disease, acquired disease? What actually is it? So here's a sort of a broad differential of deposits, and this is not exhaustive and doesn't even include some of the things, Giovanni, that we just heard about in her talk, of things that you can see. And I'll be perfectly honest with you. These things most of these things are very, very rare, and I haven't seen them just in textbooks. I've seen a few of them, and I'll kind of run through just a couple of things. First, and this was already talked about just in the last talk, these cationic amphiphilic drugs can give these Fabry-like inclusions. So this is an example of a Fabry disease, and I don't need to remind you because we just saw what this looks like, but we can see these bubbly appearance of the podocytes, and we see these whorled inclusions within the podocytes, in this case of Fabry disease. This doesn't really look like our case, but just in the differential. Hepatic glomerulosclerosis is something that was brought up. This is associated with severe liver disease, cirrhosis. Doesn't really fit because neither the donor nor the patient had liver disease. These deposits can look something that you see in LCAT deficiency, which I'll talk about next. LCAT deficiency. So LCAT, lecithin cholesterol acetyltransferase, this is the enzyme that esterifies cholesterol and harvests it onto HDL from the tissue and brings it to the liver. These patients who have deficiency of this present with proteinuria, nephrotic syndrome, renal insufficiency. They also have systemic manifestations, though. Corneal opacification is a classic one. And they'll have lipid abnormalities, mild to severe hypertriglyceridemia, as well as total cholesterol elevations. They may have hepatosplenomegaly, but it may not be present. And by electron microscopy, what you'll see is that, well, first of all, by light, you'll see this GBM inhomogeneity. These are due to these lipid deposits within the glomeruli. And I'll show you what they look like in just a second on electron microscopy, but they can be extracellular or sometimes intracellular, but a classic one would be these intramembranous deposits. You may also rarely see these large luminal deposits. One of the things I really liked about this in the differential, though, is that this has been reported to recur very early in the transplant. So, and the pathogenesis of this is either mutation. Over 90 mutations have been identified with this, or they can actually have acquired LCAT deficiency. You can get autoantibodies to this, sort of just like you see with TTP, when you have these autoantibodies to anti-TS13. But this is a light microscopic image of a patient with LCAT. Actually, this was Dave's case, and so thank you, Dave.
Look for me.
Yeah. So thank you, Dave, for letting me borrow this slide. And what you can see is, again, as I described, this sort of inhomogeneity within the glomerular basement membrane, but also sitting in some of these mesangial spaces. And what this looks like by light microscopy is this sort of Fabry-like, but not really, and it's sort of bubbly looking like ours, but not quite like, but it still could be. This was certainly considered, and we see this sitting within the glomerular basement membrane as well as within this endothelial cell here. However, we did LCAT activity on the patient, totally normal. Okay, so what next? All right, there's a rare disease called lipoprotein glomerulopathy. These patients present with proteinuria nephrotic syndrome. This can progress to renal failure. These patients usually have hyperlipidemia, but not always. That's good. Okay, so they have by light, what we see are these intraglomerular lipoprotein thrombi. And this is due to lipoprotein deposition within these capillary lumina. Pathogenesis of this is related to ApoE mutations, although there's some other genetic modifiers that are required. And I took this from this paper, Dr. Saito, who first described this in Japan. And this doesn't really look like our case, these large lipoprotein thrombi. Anyway, so we have all these other things, and I'm not going to go through them, but they don't really fit, to be honest. Many of these patients have neurologic dysfunction or liver dysfunction. It doesn't really fit. So I was left with, these are lipoprotein deposits, but there's one other thing that I considered. However, in the meantime, they did a lipid panel on the patient, and it was all normal. So I don't know if they so much didn't believe me, but they just said, well, we just don't think it's important. So they pressed on, and it wasn't my case, as I said, so I didn't pursue. But time went by, and in the interim, they got good blood pressure control in this patient, stable creatinine, no DSA. However, he continued to have proteinuria, and it actually continued to increase, and it peaked with a urine protein to creatinine ratio about 5 to 6, and it continued microscopic hematuria. So finally, they did a repeat biopsy about a year and a half later. And I showed the trichrome just because we're very happy that he wasn't scarred over, really good architecture in the biopsy. And you can see this in the tubular interstitial compartment. But the glomeruli, there were marked changes. You can see this is a previous biopsy compared to the current biopsy. There's glomerulomegaly, and there's enlargement of the glomeruli up to about 300 microns. And you can see this illustrated here. There's mesangial expansion, sort of similar to what we saw before, just more of it, more hypercellularity. There's segmental sclerosis that appeared, this sort of variegated mesangial expansion and hypercellularity that I talked about, and these foam cells. And you can see this illustrated with a silver stain. The fluorescence was essentially negative. There was some segmental staining related to the segmental sclerosis, but really negative. So here's what we see by EM. The same thing we saw before, foam cells and these electron-dense deposits. And again, they had this bubbly appearance. So the same thing was going on and progressing in this patient. Here we can see, again, these nice little sort of soap bubble deposits. But this time I had some frozen tissue. And so we did oil red O, and voila, it's markedly positive. So all this stuff is lipid or lipoprotein. So here are our findings: no rejection, glomerulomegaly, segmental sclerosis, no immune deposits, but we've got this lipoprotein deposits. But we're still left with what it means. So I told you there was another diagnosis I considered. This was based on a paper that came out about 25 years ago. This was also from Japan. This was reported by that two siblings. The one sibling had hyperlipidemia, and the other didn't. They had proteinuria, heavy proteinuria, and their lipoprotein, lipase, LCAT levels were all fine, but they had this mesangial expansion, this sort of variegated appearance, mesangial foam cells, and oil red positive glomerular deposits. And these patients also had ApoE deposits, and they were ApoE2 homozygotes. A little aside about ApoE, what is this? ApoE, there are 3 common isoforms of this, ApoE2, 3, and 4. 3 is the most common. There are 2 structural domains. One binds the LDL receptor, and the C-terminal half binds the lipid. ApoE mediates the uptake of these triglyceride-rich lipoproteins by the liver, largely by the LDL receptor. And interestingly, the LDL receptor is also expressed in the mesangial cells. Anyway, this reduces circulating lipid levels. And turns out that ApoE2 has reduced binding to the LDL receptor compared to 3 and 4. So these patients get or can get a type 3 hypolipoproteinemia. So back to this case report, this patient's had oil red O deposits and ApoE deposits by immunohistochemistry. So we stained our patient, and sure enough, tons of ApoE sitting in the mesangium of our case. And then we also genotyped our patient, and he was ApoE2 homozygote. So now our diagnosis is ApoE lipoprotein deposits with E2 homozygosity. But what about this segmental sclerosis? And I just want to finish with this real quick. I'm sorry it's taken a little bit over. But there were some other findings on EM. You can see the glomerular basement membranes in some of these regions are markedly abnormal. It's almost outport-like. There's this sort of lamellar change with this sort of flocculent material in between. To me, it almost looks like pemphigus. It looks like the surface of it is lifted off. And you can see that sort of a higher power here. You can see the lamina externa is sort of lifted off, and there's this lamellar change with this flocculent material. Well, it turns out this has been described before, and this is called transplant size mismatch glomerulopathy. And this has been several papers describing this, including this nice image from the glomerular disease published a couple of years ago. These patients get manifestations within about 4 months to 2 years after transplant, typically subnephrotic proteinuria. Graft survival is about greater than 50% after 5 years. But the kinds of findings that you see are glomerulomegaly, mesangial expansion. You can get sclerosis and collapse. So this was our final diagnosis, both of these two things. And I felt that the lipids were important, though, so I convinced the clinicians to start him on fenofibrate, and they did. His urine protein creatinine ratio decreased 0.7 over 10 months, and his serum creatinine has remained stable over 6 years. His nadir has been 0.2, but now it's recently risen a little bit, probably because his ongoing segmental sclerosis. Okay. And that's it. Thank you for bearing with me. I want to thank Dr. Howell for providing me with some images and all my clinical colleagues at KU. And that's it.